All right, good afternoon and hello everyone. Welcome to the Alliance Conversation series. My name is Corey Bryant. I'm filling in today for my colleague Deanna Fenton. She's feeling a little under the weather. And today we're pleased to focus on improving disparities in access to transplant care in the Hispanic community. We're glad to have you all with us today. I know we're looking forward to a robust exchange of ideas for today's program. Now, one quick thing to note, while continuing education credit is not offered for this program, anyone participating in this event may claim a certificate of attendance. So within 24 hours of this program, you'll receive detailed instructions on how to claim your certificate following a brief online evaluation. So please make sure that you claim your certificate within 30 days of this program. Now it's my pleasure to turn it over to the moderator of today's program, and I might add a recent recipient of the Alliance 2021 Committed Leader Award, Joanne Brooks. She's the Clinical Nursing Director at the University of Michigan Transplant Center. And Joanne, I'll hand it over to you.
Thank you, Corey. Welcome, everybody, and I'm excited to introduce Dr. Juan Carlos. He is from Northwestern University. Where he is the director of the Hispanic Transplant Program, surgical director of the Liver Transplant Program, and also director of the Living Donor Liver Transplant Program and hepatobiliary surgery. So we're going to start our talk about improving disparities and access to transplant care in the Hispanic community. Dr. Caicedo, it's all up to you now.
Thank you very much, Joanne, and thank you very much for inviting me and having me here. It's an honor, a pleasure to be with all of you today. I hope next time could be in person. It's always kind of hard to talk without seeing people, but we'll do our best. Again, thank you very much for inviting me. Then let's start. The goal in this talk really is to discuss how we can improve disparities and the access to transplant care in minorities, and specifically I'm going to talk about Hispanics. And if there's time, we can talk about the other initiatives that actually we have, for example, a starter and champion here at Northwestern. Then I don't have any financial disclosure. The only disclosure is some of the data that I'm presenting is part of my NIDDK R01 grant or data. Then we have the title of our grant is a culturally targeted transplant program to increase live donation in Hispanics. The objectives of this presentation today are to review relevant Hispanic American facts, describe disparity in Hispanic Americans' access to transplantation and living donation, and to articulate cultural and linguistic issues and Hispanic patients' preferences that can inform a strategy for improving living kidney and liver donation in Hispanics. Sometimes most of the providers focus on what they believe the patient needs, and actually my point is we have to personalize our care based on what the patient needs and they perceive that they need and what they prefer. And I think that is completely different. And that's why most of the time, the outcomes that are wanted are not achieved is because the approach is not personalized. And then we're going to describe how the Hispanic Transplant Program and Northwestern Medicine here in Chicago has been associated with increases in living kidney and liver donation in Hispanics. Then very quickly, we're going to review some relevant Hispanic facts. First of all, from the US population, 60%, and Joanne, can you see my arrow and if I'm trying to point something? Then 60% of the population are non-Hispanic whites. Then that means that 40% are no whites, are part of minorities in general. Then 40%, keep that number in your mind. From them, Hispanics, out of 320 million or more people that the US has, their Hispanic Americans are 60 million. They're 18.5% of the population. We are the largest minorities, as everybody knows. And Hispanics accounted for more than half of the nation's growth in the last decade. And now I'm going to provide some specific data data that are going to be relevant in transplantation later on. First of all, Hispanics are a very young community. The mean age is 30 years old. Then here you can see how the Hispanics are growing across, in US as well, in general through the years. Then here you're going to have a visual representation of that very quickly. Then this is the 1980s. You can see Hispanics were more in the Southwest and a little bit in other areas, but this is to 1990. This is slow to pass, 2000, and this is 2011, 2006, and 2011. Now, as you can see, Hispanic has spread throughout the country. Now, from all Hispanics in US, 62% of them are from Mexico. And also that is relevant. And we're going to talk a little bit about that later today. But also depends on the area of the country. You can have more, for example, Cubans more in the Southeast, or you can have more Puerto Ricans, Central Americans, or Caribbeans in the Northeast, for example. Now, another important cultural fact about this community is Hispanics, they have big families. For a lot of people, this is a social problem, but we're talking about organ donation and transplantation. Is a huge advantage, and most of the transplant programs are not taking advantage of this fact. Then why to talk about Hispanics and why other industries are talking about Hispanics? Not necessarily because they want to help the poor Hispanics. What they are looking is the Hispanic consumer. They are drivers of the economy right now. Is one of the biggest drivers. The baby boomers are retiring right now. They're now buying tablets, cellular phones, and other technologies and other goods. And Hispanic consumers spending 1.3 trillion. In case my Colombian accent doesn't convey the T in English, is with T, trillions. It's a lot of money. That's in 2015. And this is the growth of this buying power in this community. By 2020 was 1.5 trillion. And the total buying power has increased in this community in 212% in the last decade. That's why the companies, other industries are advertising in Spanish. Hispanic markets is one of the main drivers of the overall consumer markets. Now, let's focus on transplantation. This is our field, and that is what we care. Then let's talk about kidney waiting lists and transplantation Hispanics. Then this is very well known for everyone. In this call, on this webinar, there's a lot of people waiting for organs. And if we go to 2020, the whole data, we have a lot of patients waiting. Right now, there's more than 100,000 patients waiting for a kidney transplant. And this is the tip of the iceberg. There's so many more patients that needs to be on the waiting list, but they are not. Right? There's like 700 or almost 1 million patients on dialysis or has chronic kidney disease that probably they should be listed or they should be considered for transplantation, but they are not listed. Then there's huge access issue for this patient. Not everyone can be transplanted, but a good proportion of them can be transplanted, and they are not even wait listed. And from them, a very small proportion is getting a transplant. And most of them are from deceased donor, very few from living donor. There's a huge gap that is growing. That is the main issue in general. And unfortunately, almost 5,000 people are dying every year because there's not enough organs and they're dying from their kidney disease. Then, well, let's go to the next. Now, let's talk about the kidney transplant waiting list by race and ethnicity. Then remember that we're saying the few slides before that whites or non-Hispanic whites were 60% of the population, the majority. But here on the waiting list for kidney transplantation now are becoming the minorities. If we analyze from the rest of the population, there are only 36% out of 60% that they were as a whole in the population. And the rest that were kind of the minorities now become the minorities become the majorities. They are 64% of the patients waiting. This is important. And here is where I have been telling the rest of the country that we're missing the boat, because most of the programs are not developing initiatives to help most of the people that are waiting this. I was surprised to see that, for example, out of 250 transplant programs in the country, only 8 or 9% of them has their website translated in different language besides English. Only 9%. Then when we're looking for any type of culturally sensitive initiative described in the website, and the website has a lot of issues too. There was 3 centers where without even a website identified, right? But in general, and there's not always everybody publish everything that is they are doing, but we use that as a surrogate just to have an idea. But the point here is out of 250, only 4% of those kidney transplant programs were providing some information about any type of culture sensitive initiatives. We're looking for anything. We're not looking for high quality cultural sensitive initiative. We're looking for anything. And then it's not so much about quality. We're talking about just the number, just to have an idea. It's only 4%. This is insane. How come we don't have more Hispanic, African American, Asians, or whatever programs, right? Because that is the majority of our patients waiting. Then here's where I believe we're missing the boat, and we don't understand really who we are serving. And no one approach fit all. That I think is wrong in any industry, and the same even more in medicine. The surgery, the kidney transplant, probably the same kidney transplant in any race. There's no difference so much about that. But the approach, how we approach the patient is what needs to be different. That is what we are not doing in the country. And then unfortunately, minorities receive fewer kidneys from living donors compared with whites. Then here, by 2020, you can see, and you can compare with 2019, that was more normal year. 2020 with COVID, let's don't look at too much that data. You can see how whites, from all whites that receive a kidney transplant, 42% were from living donors, but here Hispanics only 24%, and Asians 25%, and African American only 14%. Keep in mind that number whenever we start talking about our own experience here at Northwestern. Then some quick facts about Hispanic Americans and kidney transplantation. They have the highest growth in kidney transplantation workplace, and it's no surprise because we know as a population they have one of the fastest growth. And as a whole, an absolute number, they have the fastest growth in general. Now, one of the longest waiting list time, and they have one of the highest waiting list mortality when we compare to non-Hispanic whites and African Americans. But also there is a Hispanic paradox that has been described in other medical fields, but also we wrote about that in kidney transplantation. As soon as you transplant Hispanics, they have the same or better outcomes compared with whites. And unfortunately, the Hispanic Americans are disproportionately affected by organ shortage, as they have high prevalence of renal disease due to diabetes, hypertension, obesity, and they exhibit low rates of living kidney donation compared to non-Hispanic whites. A lot of providers said, you know, minorities and Hispanics, they don't follow recommendations, they are not good patients, they don't have good adherence, they don't donate organs. And I think that is not the patients, it's us. We have to blame ourselves too, because we're not doing a good job having a culturally and linguistically initiatives to customize or personalize the care that we're providing to our communities. There's different barriers or multiple barriers for patients and potential living donors, including language, including difference in dialect. But let me just mention one thing that opened my eyes before I start and develop the Hispanic Transplant Program here at Northwestern. One patient told us that he called 9 transplant centers. As they answered in English, he just hung up. And he had a private insurance. And a lot of people think that the issue with minorities is the insurance, and actually is not. Sometimes the first issue is the language barrier. And we don't have phone lines in Spanish, for example. The second, there's cultural difference between patients and providers. And there's a lot of distrust, not only from the patients to the providers, but also between the providers. You know, sometimes they don't want to serve certain communities, and they have a specific biases. There's a lack of community awareness. There's misconception about organ donation transplantation. And there is barriers that impair access to preventive care, health education, and some treatment options. Now, in this table, I'm just presenting data from two studies that we did. In the right column is a study where we survey all the kidney transplant programs in US. We are very interested to learn, to understand how they were providing education to Hispanics. And then basically most of the centers were saying we're providing education in English. They are relying on written material. They were doing a one-on-one discussion. And the educators were non-physicians, the nurses, social workers, PAs, and they rely upon interpreters. That is what the centers were doing in the US. But we did another study where we're asking the patients what they would prefer. It was very clear that they would prefer in Spanish, the education. You have to know and realize that 75% of the Hispanic population in US, they speak Spanish at home, or they would prefer to talk in Spanish. If you're talking about life and death situation, like you're in dialysis or you have organ failure, you're going to die, they will prefer to speak in Spanish. And they prefer face-to-face interaction instead of written material. They prefer group discussion, and this is very important. Because how is the best way to scare people away? And everybody does this because it's part of the regulation that we have, or well, we're pressured by the regulatory bodies, and everybody is just meeting with patients one-on-one. We're telling them the risk, what can happen, how they can die, all the complications that they can have. And if they're overwhelmed with the news that they have organ failure, they need a transplant, you're telling them all of this, they're scared. But if you have family and friends with them, they can support them, and they can make easier the process. Always the analogy that I use here is the analogy, I'm comparing we, the Hispanics, with deers. If I'm the single deer in the middle of the jungle, and I sense that something is moving in the bushes, and maybe it's a tiger, if I'm a single deer, I'm not going to stay there. I'm just going to run right away, right? But if we have 10 or 20 deer, they're going to start looking at each other. One of them may die, but they will stay longer there because they feel more comfortable with seeing more of their peers. Then basically one concept here is Hispanics prefer group discussion, and they prefer to receive the education from physicians. Just want to remind people, in the Hispanic culture, MD means medio Dios. Translated to English is half God. They really appreciate and respect the priests and the physicians, and they will feel more comfortable if the education is given by physicians. Then my point is not that the social workers, nurses, or PAs don't know the talk that they're given. Probably they know better than even physicians, and they're more willing to do it. Physicians like me, they feel like you're so busy that they don't want to spend time. And as I was mentioned in the introduction, I do kidney, pancreas, liver, small bowel, and adult and kids, do hepatobiliary transplants, hepatobiliary cases, and well, a lot of things. I'm very busy, but I really think education is essential, and we have to contribute. Physicians need to contribute. Everybody needs to contribute. Education is not one-time event. It needs to be, you have to repeat the message multiple times until the patient understands, or the family understands what we're talking about. They now are inviting physicians to help in the education instead of just leave others just to provide education. And the Hispanic community, they trust more, develop the bond with the physicians if they are given the talk. And they prefer bilingual, bicultural educators and no interpreters as much as possible. Now, in the living kidney donation decision-making process, there's 3 key elements. Then the first element is the decision makers. In this community are the elders, grandma, la abuelita, disseminations, Elders are the ones that make the big decisions. Know what tablet or phone to buy or technology to buy. They don't care about that, and sometimes useless. But if you are dying or you're getting married, you're going to talk with grandma in this community or with the elders. The second, you have to address the fears and concerns or misconceptions of the family of the support network. And the third key element in this decision-making process, are the patients. Then now, the most the issue in most of the program is they are only addressing the information, or they are talking only to patients. They are not bringing the decision makers of the family. And that's a problem. That's why the approach doesn't work. Then you have to convince grandma that the right thing to do is to donate an organ. And I use a lot of religion with them. They're very religious. The Hispanic community, 95% of those are Catholic or Christian. Then when I'm telling them that John Paul II, a very charismatic Pope, used to say that the biggest act of love was to donate an organ, grandma opened their eyes and they said, oh my God, this is great, and I want to be a donor. Then believe me, my goal is not to have grandma to donate organs. Although some grandmas or grandpas can donate organs too, but that is not the goal. The goal is to have the blessing, and if they give the blessing, one of the 8 or 10 siblings, for example, they can consider to be a donor if you address their concerns. If you are talking to females, Hispanic females, the main concern is if they can have babies, if they can become pregnant. But if you're talking with a young Hispanic male, the issue or the concern is if they can have normal sexual life or sexual performance. Then you have to address those. If they can work, if they can exercise, they can. If they need to take medication for life, that is not true. Then if you address those and they have the blessing from grandma or the elders, they're more likely they can move forward. And sometimes the problem is the patient. Most of the time, 70 to 80% of the time, I believe the patient would say that they don't want to consider any living donor. They don't want to have the loved ones. Then you have to convince them, and then you have to explain to them and remove any of the misinformation that they may have. Then this is the basis of our intervention, what we have done. Then we developed the first Hispanic transplant program in the nation as a response to the Hispanic health disparities in transplantation and to meet the need of this growing population in our area here in Northwestern and here in Chicago and in Illinois. And we developed a comprehensive, culturally and linguistically competent and congruent Hispanic transplant program. We were the first one in the nation. We're very proud. At the beginning, I was kind of surprised because I was assuming that everybody has Hispanic programs. Because it's the largest minority with the fastest growth. But actually, I was surprised to see that nobody has Hispanic transplant program at that point in 2006. We developed the first Hispanic liver transplant program in 2010, and now we have close to 50 people working with me. I started by myself, but now I have 49 people, part of our team that are bilingual, bicultural, to be able to serve this population. And now we're providing the complete experience in Spanish if the patient or family needs it. Very quickly, I'm going to review our outcomes, what happened, then what we have done. Then basically, as I said, we have the bilingual, bicultural staff team members. We provide all the information in Spanish. We target the 3 key elements of the decision-making process, as I mentioned, the Hispanic patients, family decision makers, elders, and then we provide the education in a face-to-face fashion in a group setting instead of one-on-one. The education is provided by a physician, in this case, a transplant surgeon, and we focus on cultural, language, health-related financial concerns, preventing Hispanic families from considering living kidney or liver donation and kidney or liver transplantation. And we have decreased the use of translators. Then now, as I mentioned, we're trying to remove all the barriers, including the language barriers. We address issues related to culture and education, influential role of extended family, religion, lack of knowledge, fear of donation, and fear of surgery, cultural desire to avoid harming potential donor, resulting in not asking for donors. And that's why when people in the clinic are seeing the patient by themselves and they are asking to the patient, do you have donors? Most of the time the answer is no. And to me, it's a mistake. You have to bring the whole family, and when you ask the same question in front of everyone, now it's just lovely to see that the patient said no, and the daughter or son or who else, some family member will say, of course, ma, or of course, grandma or grandpa, I want to give my kidney to you. And they start talking, and it's just beautiful. You just stand by and just listen and see that beautiful thing. And that is an act of love. And then actually just, bring together the family. And we address healthcare professional attitudes and biases. That is really important to deal with. And financial legal concern. There's a lot of misinformation. For example, about undocumented patients. There's a lot of misinformation about that. And what are our outcomes very quickly? First of all, here is just to show how with this type of education and knowledge in, the difference in culture, we were able to improve knowledge and attitude towards living kidney donation in patients and family in a significant way. Also, when we compare the Hispanic Transplant Program, after implementation compared with before implementation of the program, we can see, and just to give you an idea, in Northwestern, we have done more than 5,000 kidney transplants. We're doing around between 200 and 250 probably this year. We're going to be close to 300. And we have improved access to the transplant care measured by the additions to the waiting list in 91% in Hispanics. When in non-Hispanics wide in that period of time, increased only 4%. We're able to increase living donors, kidney transplantation in Hispanics in 74%. And we're able to increase even living donation in 62. We don't control when patients die and we can have donors, but what we have done differently is we educate well these patients, and they were willing to take a DCD, extended criteria donor, high KDPI, all this stuff. And then they're ready and they move forward. And more importantly, we're able to decrease the disparity. And the metric that we use here is a ratio between the Hispanics and non-Hispanic whites living donor kidney transplant. That we're able to decrease the disparity in 70%. Then initially, I was thinking that everybody was having the same outcomes, and I'm going to show that in a moment. But I just want to emphasize every year is different. But here, comparing US with Northwestern in purple, there's years where Hispanics have higher proportion of living donor kidney transplantation than even non-Hispanic whites and Asians. And our proportion, Hispanic receiving and living donor kidney transplant here in Northwestern has been between 65 and 80 in some years. Then before we started the Hispanic program, here in Chicago is a very competitive market. Other centers were doing more Hispanic transplant than us. And very quickly after we implement the program, we just start leading the market doing kidney transplant in Hispanics in Chicago. And this table is very busy. I'm not pretending that you will read it, but the message here is, initially I thought these outcomes, everybody was seeing the same outcomes throughout the country. But when we analyze the other centers in my city, as well as the centers in other cities with a high concentration of Hispanics, that you can see in this table, that summarize that, if you see programs in New Jersey, Connecticut, Rhode Island, Florida, Texas, Arizona, California, Illinois, Colorado, New York, nobody was having similar outcomes, the outcomes that we're having here in Northwestern. Then we believe that if people start adopting this type of initiatives, even if the adoption rate of this initiative is low, 10, 20, 30%, and even if the growth of the living donors percentage is very small, 5 or 10 living donor kidney transplant per year, we can have a huge impact in the annual national number of Hispanic living donor kidney transplant. We can increase the number between 10 to 66%. And actually that is our grant. Now we're finishing our grant. We have a very exciting news there, and if we have time, we can talk about that. Then we started our Hispanic liver transplant program in 2010, and we have done here more than 2,300 transplants. And we saw certain patterns. Then, for example, we improve access to transplant care, measured by the addition to the waiting list. And Hispanics, they grew here in 54%. And you have in the nation was in that period of time, these 2 period of time, the growth in the addition to the waiting list in Hispanic was only 25%. And you can see what was happening with Hispanic whites or in Northwestern as well in the US. The number of liver transplant increased in Hispanics in 54%. The number of living donor liver transplant, and look at these numbers, very interesting, 88%. Even liver donation is a bigger deal. We have our living donor and the Hispanic liver transplant program is a smaller program and it's kind of newer, but still we see the trend. The numbers are increasing, and even the deceased donor liver transplant is increasing because patients are ready, are better educated, and they're more willing to accept different type of donors. Before, people were worried to accept because they didn't understand. Here is education is key. And then, so far, our Hispanic transplant program at Northwestern, we have done more than 1,200 transplant Hispanics. We have done more than 900 kidney transplant Hispanics. 52% from living donor, when in US was only 24%. And before the Hispanic transplant program, Hispanics in Northwestern were only 9%. Now are 25% of all patients that were transplanted here. Now it's 1/4. Then also we are doing, oh, this is not moving. Okay, we have done more than 260 liver transplants in Hispanics, 10% from living donors, when in US, the percentage of living donor liver transplantation is 4% overall. Then here, even Hispanic has double the proportion of living donors compared. We're also, we have done SPKs, pancreas alone, pancreas after kidney, and other organs. This is our Hispanic transplant, Northwestern Hispanic transplant team. And we're very proud about that because it has been little by little that we have been building it. Now we have the largest, probably more comprehensive program because we have now a full team that provide care to this community. In conclusion, just to be able to have time to discuss, because I think this is the most important thing, and hopefully we're going to have some discussion. If I can hear voices, that would be great. I don't know if that is possible. But in conclusion, culturally targeted transplant program can increase patients and family knowledge about living kidney donation or liver donation, as well increase favorable attitude towards living kidney donation or liver donation, perhaps contributing to the increased number of potential donors initiating evaluation and number of living donor kidney transplants. Our culturally sensitive strategies can help to reduce living donor kidney transplant disparities in Hispanics. And also similar strategies may be useful for other ethnic racial groups. And I can tell you, I'm happy to report here at Northwestern, we developed the first African-American transplant access program in the nation, led by an African-American surgeon, is the first African-American transplant surgeon in Illinois. And following what we have done for Hispanics since 2006, now for 3 or 4 years, she is leading this initiative, and we're improving access and transplant rate in African Americans with a culturally targeted approach, right? It's just to understand the need of transplants is there, but the approach needs to be different, and that is something important. And also I'm saying, applying this type of strategies could be helpful for the organs. Then I showed the initial numbers on kidney transplant, and now I'm showing numbers on livers. And actually just last week, AJT accepted our paper from our R01 or the NIH study that we're doing, where we demonstrate when transplant centers implement with good fidelity our approach, they get the results. Then they are improving in a significant way the number of living donor kidney transplant. Then to close, initially I was saying there's the perception from a lot of providers in the US that minorities are no good patients, they don't have adherence to medication, they don't follow recommendations, they don't donate their organs. This is crazy. What I'm saying, that is false. based on our own biases, or has been the issue. And if we recognize that who is our patient, and we customize, we personalize the care of these people, we can have different outcomes. And that is what I'm providing. That what has been a perception, I'm showing that that is not true, and you can do something different, and you can have good outcomes, and you can have impact in the communities. And I believe if we do this type of, or we recognize the patient's difference, patients and family, culture, and linguistic difference, and we provide personalized care, we can have this type of results in other groups, African Americans, Asians, or whatever group you're taking care, where you program or you OPO or wherever you're working. Then I mentioned this for living donation point of view, but also I'm board member of our OPO. And when we focus on education to the Hispanic community, and we have, for example, requesters that are bilingual, bicultural, we have been able to show how Hispanics even have higher proportion of the, how it's called, not the transplant rate, when they accept the donation, they have higher number when they are educated. Then I think that I believe that is relevant for living donation as well deceased donation. Then I just want to have some time. I think it's 36 minutes. I want to have some time to discussion. Then I will stop here. Thank you very much. And I'm looking forward to hearing your questions or comments.
Thank you very much, Dr. Caicedo. Truly an insightful and really valuable presentation. So I'm sure many of you have questions for Dr. Caicedo. If you would, just pop those into the chat, and I will hand it over to Joanne for Q&A.
Thank you. The first question that came up in the chat is, does this data include pediatric patients?
I'm sorry, give me 1 second. Sorry, I'm uncovering children's and it looked like there's an offer or something. That is a problem. Sorry about that. Sorry about that. Sorry about that. My apologies. All right, I'm sorry. What is the question?
Does this data include pediatrics or?
This data is adults, but also I'm a pediatric transplant surgeon and in Laurie Children's, and we have also a Hispanic nephrologist, and we're trying to replicate the same thing. But I don't have the data. I don't have the numbers to say yet in pediatrics.
And regarding religion, what handouts or tools do you guys use when speaking to families?
Then basically we have developed, actually we receive a HRSA grant. And then for example, we developed a website that was bilingual, bicultural. We finished the grant, and we published it, and now that website is available to anyone. It's called informate.org. Informate, INFORMATE.org. Then this is available to anyone that you want to use it. It's in ASTS, in UNOS, and other organizations. You can find it there. You can use it. Please do it. That's why we did it. And then we have some pamphlet in Spanish and English and videos in our website and everything. Then it's just to make easier for anyone to understand. Even in the website, there is videos and some novelas in the Hispanic community. They love the soap operas. Then even if grandma doesn't read, she can listen or watch the video, and then she will be informed. Then the idea is to make sure that everybody learn.
The next one isn't a question, but a comment they wanted to share with you. Thank you, Dr. Caicedo, for this amazing educational presentation, for saying it like it is and addressing all the key issues, providing tangible, proven, successful ways to better serve our fast-growing Latino Hispanic community. You are a pioneer, a leader, an icon, and such an inspiration to all the Latino professionals working in this field. Thank you for representing us so highly. God bless you.
Oh, thank you for that kind words. I really appreciate it.
Then there's another question. Who leads the investment of resources and research in developing your robust program?
Right. Very important question. And I think, you know, everything in life is not about money. It's if you want to do it and you figure it out. Let me tell you, my budget for marketing, right? Because some people say, give me $5 million and we'll make it happen. My budget marketing was zero. And when I started the program and I was talking to media, media was saying, well, you know, Northwestern is a rich hospital, give me money. And then I will start talking to you and show your program. Then the strategy was different. I went to the media and said, if you need anything about adult or pediatric kidney, liver, pancreas, small bowel transplantation, or hepatobiliary surgery, I'm your guy. Only if it's a positive note. I did not allow them to talk about some crazy political stuff because it's nonsense. If it's positive and it was about education in the Hispanic community, I was the guy and I'm the guy. And now I have been in more than 1,300 TV, radio, podcasts, internet interviews, and, you know, I have been all over the place, but with that huge budget. Then my point is, initially I was the only one, but then I started looking at my team and my hospital and other, who is a Spanish speaking nurse? Who is the receptionist that speaks Spanish? They say, can I borrow your front desk person for my clinic that is 2 times per month in the afternoon for 3 hours? Then I start getting this one, the nurse. And sometimes people don't know even their own census. Part of what I have learned in my grant, when I have done study sites, I go through the program and said, I don't have any bilingual nurse. I don't have any Hispanic because they have different, you know, faces. And I said, can I talk to your team? I said, sure, go ahead. The first guy that I start talking, a tall, blonde, blue-eyed guy, and with a European last name. And I start talking to him, say, oh, I'm from Argentina. There's a lot of Europeans going to Argentina, and he was Spanish speaking. My point is, you cannot assess people based on your last name. If you're Maria Smith because you marry Mr. Smith, but maybe you're Maria Gonzalez and you don't know that, and you're going to say Smith is not Hispanic, then just rule out. Then don't rule out people neither for your face or your appearance, nor by your last name. You have to ask people. I guarantee if you are in an area with a high concentration of Hispanics, most of a good proportion or reflection of the population where you are, you're going to have some of them are going to bilingual. But you don't know until you ask. But the problem is nobody asks. Then the first task is do your census. You figure out that you have more than you believe. And the most important thing is just want to do it and just figure out. And you start one by one. What is the quote? How you walk at 10,000, I forget. How you eat an elephant, one bite at a time. The journey of 10,000 steps, start with one step. Then you need to start. Do your first step and you figure out. Nobody's going to give anyone $5 million to start programs. You start little and then you start growing.
The next one is, I work at a liver transplant center in Arizona. Why are transplant centers hesitant to make necessary changes? We have such a large Hispanic community.
What is the question?
Why are transplant centers hesitant to make the necessary changes when there's such a large Hispanic community?
Don't know. It's a good question for them. And I can tell you one of my study sites is in Arizona. And we have trained here in Northwestern 13 or 14 fellows that are Hispanics. One of my fellows is going to Arizona too. Another fellow is back to Arizona too. Then we're sending people there. Maybe, I don't know what center is, but there's interest in other centers there because there's a clear need.
Do you have a Hispanic kidney transplant program in addition to the liver transplant program?
Yes, all this data is from the Hispanic Kidney Program. Most of the data is from the Hispanic Kidney Program.
Next one.
But we have Hispanic Pancreas Program, Hepatobiliary Program. Everything that Hispanics need, we have it here.
This person wrote, I live in Arizona as well. Unfortunately, I feel like our hospitals do not care enough to invest in the Hispanic community. What are some of the things you recommend we address with those in positions of power to move towards a more inclusive approach when it comes to transplant programs and education? Right.
Then I would say this. I will make a financial case because they are the administrative people, that they just care about money. Then I make the case earlier, if you are in an area with a high concentration of Hispanics, you can grow your program. I grew the program. Even in 2012 or 13, Northwestern was #1 in the nation doing living donor kidney transplant. And we were #1 only because we grew Hispanic, the number of Hispanic patients or the Hispanic program. Just based on the number of whites was not enough. Then what is different was the growth of Hispanics. Then you need to understand the market that you're serving. And if you ignore that, you're going to lose a huge proportion of patients right there. And the other comment, and I'm not going to politics, I usually don't. This country is a very diverse country. And that's why it's the best country on earth, because it's so diverse. Everybody has immigrated to this country. Only 1% of our population are Native Americans. The rest, we have migrated in our lifetime or in our previous generation. Everyone is an immigrant. And then we have to embrace our diversity. And if we embrace it, everybody will benefit. Even those hospitals can benefit financially if they open the door to do this transplant.
You mentioned religion plays a huge role in the Hispanic community when it comes to making major decisions such as donation and transplantation. Just recently, I heard from a few Hispanic families that the reason they haven't registered or even gotten vaccinated is because they rely on God for healing. Any suggestion on how we combat that?
Right. Then the first thing is misinformation. And it's so sad because most of the religions are in favor of donation. The leaders, John Paul II, Paul Francis, are in favor of donation, right? But the problem now, I'm not going to politics again, but the fake news and everything in social media, people writing about everything and they are no expert in nothing, that is dangerous. That is killing people in US. In my mind, we have to be very careful from where the information is coming. Then, if you're talking about transplantation, you need to talk to the expert about that. If you don't come to me and tell me how to fix your car, I don't know expert in mechanics on it. Don't talk to me about that. I'm not the expert. But the same in any area. Then the problem is when people listen and believe from others that are not expert in that area. That is dangerous. And here's the problem with media. This is the problem with politicians. They're based their comments in no data, no evidence whatsoever, and that's dangerous. And that is really dangerous, and people are dying for that. Then for transplantation, for vaccines, and it's insane. But again, here in this country, there's a lot of politics, and that has been dangerous.
Does your Spanish speaking staff have to pass a test where they are certified to speak medical Spanish? This person's, many of their bilingual staff cannot pass the test that is offered, and so they are not allowed to translate, and it's very difficult to get medical translators.
Well, you know what? That is part of the, sometimes is the biases of the leaders or the administrative people in hospitals, because they always want to do the double translation back. I remember when I started here, I'm Colombian. I don't speak English. I don't claim that I speak English. I'm from Colombia. We have one of the best Spanish. And then they were questioning, but how we can trust you that you can speak Spanish? I said, you know, my point is, and when people ask sympathy for patient and they really try to speak the language, even if it's not perfect, if they greet the patient in Spanish, if they're trying to understand, that means a lot for patients. Then I believe that something's better than nothing. When nobody understands the language or don't understand that culture, that is pretty bad. But if people are compassionate, and they should show sympathy for the patient, even if it's not perfect Spanish, that's better than none. And use them, because they will help and they really care. And I think here it's about motivation. It's again, it's not about money. It's about where you have your heart. And if these people that maybe don't have a perfect Spanish, but they really care about this population, and they put their heart, their soul to help them, I would trust more them than others that don't care and maybe are certified translator. I have had the two sides of the coin. Certified translator that the translation is bad if they are doing it with biases and they're not translating what you're saying. Now that I understand both languages and the translation, you can be so certified, but and then eventually you start getting the right people. But also we have decreased the number of translators, because you need to understand the culture and the language to have the efficient. Now, I have to clarify, if you don't have anybody that speaks Spanish, then you have to use translator, no question about it, and needs to be certified to make sure that they're good enough.
Can the undocumented receive an organ transplant, and can the undocumented donate their organs?
Absolutely, great question, and I appreciate it. I think more than 12 million people are undocumented in this country. And non-citizens donate 3% of the organs, and non-citizens are receiving 1% of the organs. Then basically the non-citizens are receiving 3 times more organs. They are donating more organs than they are receiving. And by the way, undocumented people are paying taxes. That's another political statement that's wrong. The IRS, Uncle Sam, never lose money. There is a ITN. This is called, the ITN number is, if you don't have Social Security number, there's a number for people that is given, like undocumented people, to be able to pay taxes. Then if there's 12 million people, they contribute with $12 billion in US. Then when people say, oh, it's not fair to transplant them, they don't pay taxes, they are contributing with $12 billion. And if you are undocumented, you don't have Social Security number, you can be assigned a number, and a 9N number in UNOS, and you can be transplanted without Social Security number. Then conclusion, undocumented provide 3 times more organs that they're receiving in the first place, and it's unfair. In Illinois, 4.5% of the donors are a non-citizen, and only 1% are receiving an organ. That is unfair. And they pay taxes, and they can be listed, and they can have private insurance too. This insurance company are no dumb, and then they allow to non-citizens or people without Social Security number to buy private insurance because it's part of the market. They understand the market, and then they're allowed. But there's a lot of misconception about that in the country. They say, "Oh, you don't have Social Security number, you can't access to private insurance." That's not true.
One last question, because we're just about to the top of the hour. Any suggestions on how to get transplant team members and medical providers to not use family as translators? There are ethical concerns with that.
I'm sorry, you saying what?
The question was, any suggestion on how to get transplant team members and medical providers to not use family as translators? There are ethical concerns with that.
Yes. The problem is sometimes the family believe they want to protect their loved one, hiding information. And this is true for Hispanics, sometimes it's true for Asians. They don't want to tell the family member what really is happening. They trying to hide that information. And that is dangerous too. And then we have to be very careful with that. Then we, and also with translator, we want them to translate exactly what we're saying, the whole concept. And that is a problem. And that's why we have to evaluate our translator well to make sure that they are doing a good job translating everything that we're saying and conveying the information without hiding anything based on any type of biases. Then that is the evaluation that is necessary. Not only you're proficient in a language and in the culture, but also if you're translating everything without biases.
All right. Well, thank you both so much. Our thanks to Dr. Caicedo for truly a fascinating and very insightful presentation. I've been following along in the chat. Lots of complimentary comments saying how valuable this presentation was. So we thank you for making yourself available today. And to Joanne for moderating, and to all of you for attending. Thank you so much. And Dr. Caicedo, would you like to close us out with any comments?
Yeah, no, thank you. I'm very grateful for the invitation. I wish you the best and thank you for having me. And hopefully next time we'll be in person.
Absolutely. Well, thank you all again. We hope you have a wonderful rest of your day. Take care.
Thank you.